Thank you.
Thank you very much, dear Carlo, dear Jean-Baptiste, dear colleagues. It's really a pleasure to be here. So I'm going to give my humble contribution speaking about the role of the autonomic nervous system in atrial fibrillation treatment. What I will try to convince you in the next 2 hours, I'm joking, the next 15 minutes, is that, I mean, this role, in my opinion, is unclear. And of course, I mean, we're going to need more research on the topic. When this topic was first assigned to me, the first question that I had, to be honest, was that why Carlo assigned me this topic to me. Probably I thought my wife is a neurologist, and then that was my first thought. But the first thought that I have, honestly, is that atrial fibrillation and the autonomic nervous system stand in the equation like, global warming and electric cars. There's a lot of discussion about the fact that electric cars could really help to tackle this big problem of climate change. And so there are multiple papers. I have to say that I didn't read throughout all these papers, but I mean, there are some papers coming out that saying that probably CO2 emissions will not be lowered by electrical cars. But let's talk about what we actually know, and I'm not going to explain you that atrial fibrillation is a very complex disease. It requires usually triggers and a substrate for maintenance. Pulmonary veins, as you already seen in all the presentation that actually preceded mine, are really critically important in the initiating atrial fibrillation. And of course, I mean, what has been clarified is that why these ectopic foci are just initiating in the pulmonary veins. One possible explanation has been given, especially in the experimental setting, about the possibility of an association between paroxysmal discharges of the autonomic nervous system. I will call ANS for brevity. So I take, just 1 minute to explain you a little bit why, autonomic nervous system can really play a role in AF inducibility. So as you see, autonomic nervous system is made by adrenergic and cholinergic fibers, and cholinergic, adrenergic and cholinergic activation is really necessary for AF inducibility. In particular, adrenergic activation can actually enhance automaticity, and can also increase trigger activity through an increase in the number of early after depolarization and delayed after depolarization. Probably the work of Luigi and Andrea on the repolarization will give more answers about that. So adrenergic activation can increase pretty much the calcium concentration inside the cells, and this can actually give birth to ectopic activity. On the other side, cholinergic activation just has the possibility to decrease the duration of action potential, also to create a sort of spatial heterogeneity in the atria, and this can create the substrate for maintenance of atrial fibrillation. So, cardiac autonomic nervous system consists in an extrinsic and intrinsic components. Just for all cardiologists, you know that autonomic nervous system, ANS, is composed by preganglionic and postganglionic neurons. Usually the sympathetic system has this region of interest called ganglia outside of the heart, usually are actually besides the spinal cord in the cervical thoracic region. And the stellate cervicothoracic ganglia is one of the targets of the therapy. We will see briefly afterwards. We have also to understand and to remember that there are sympathetic fibers connecting the renal arteries to the sympathetic chain, and this is also another target for treatment. On the other side, parasympathetic innervation comes from the medulla oblongata through the vagal nerve fibers to the heart, and the ganglia are not outside the heart, are inside the atrial cell mainly, but also in the ventricle. Another thing that the vagus nerve does is sends afferent fibers to many regions, and one specifically that is useful for target for the therapy is the tragus in the external ear. Just briefly, I'm not gonna go through, I know, a lot of discussion about that. I mean, I just show you results of the renal denervation and catheter ablation. So in patients with paroxysmal atrial fibrillation and hypertension. So when you add on top of pulmonary vein isolation, renal denervation in this selected population of patients, you can actually see how the results of our ablation are improving. So you can see that patients with pulmonary vein isolation got a 12 months recurrence that was around 40-45% against 25-27% in the group of who actually received also renal denervation. So that's a good point in favor of renal denervation. Tragus stimulation is another, interesting, trial, just to understand what we can do other than ablating these patients. So I'm presenting you the results of the TREAT-AF, so it's a transcutaneous electrical vagus nerve stimulation to suppress atrial fibrillation. In this patient, in this group, I mean, there was like a randomization between the stimulation of the tragus and the stimulation of the lobe of the ear that is free from vagal innervation. So the author showed clearly that there was a reduction of the AF burden, though there was no change in the total AF duration and no change in the longest daily AF duration. What about stellate ganglion block? So this is a study published by the group of Lefteriotis. Actually, they studied the acute effects of temporary unilateral stellate ganglion block through lidocaine, and they studied what actually was happening to the human atrial electrophysiological properties and to atrial fibrillation inducibility. So what they showed very clearly in this study, that when you block the stellate ganglion, you get an increase in the effective refractory period of both right atrium and left atrium. And I mean, this is just an example where you can see that a patient was actually clearly inducible before stellate ganglion block, and it wasn't afterwards. So clearly, I mean, stellate ganglion block can have a role in the treatment of atrial fibrillation. We got a case with Andrea speaking about a different field for PVCs. But for sure, what is of major interest for electrophysiologists is what happens in the ganglionate plexi. Ganglionate plexi are mainly for atrial fibrillation located, of course, in the atria, and this actually have been, the center of interest in the last years. Ganglionate plexi are embedded in the epicardial fat pads and can have dimensions that can really vary a lot, but mainly they can contain over maximum 400 neurons. The important information that ganglionate plexi contain inside both sympathetic and parasympathetic fibers elements, and they also have a variety of neuropeptides and neuromodulators. So the highest density of these ganglionate plexi is in the posterior wall of the left atrium, in particular at the junction between the veins and the atrium. And another important information, but this actually doesn't concern the treatment of atrial fibrillation, is that especially the inferior ganglionate plexi, the right side, are connected to the conduction system, so to the sinus node and the atrioventricular node. This is just a beautiful transparent picture of an ovine heart with a special coloration that can actually show you exactly how these ganglionate plexi look like. In the humans, of course, this can be a little bit more difficult. Probably the model of the heart developed in Minneapolis will help, to also visualize the ganglionate plexi in human hearts. But I mean, the main we have two methods to localize ganglionate plexi in the atria. One is through high frequency stimulation, through all the left atrium or the right atrium, and usually, when you stimulate a high frequency, the ganglionate plexi, you can have like a bradycardic or a hypotensive response. And through the 3D mapping system, you can localize them and use them as a target. The other possibility is to look for fractionated electrograms inside the atria, but this actually is an approach that you can actually reserve mostly for a patient without atrial cardiomyopathy or, with a normal heart. So let's see what are the data in favor of gangrene plexi ablation. I'm going to cite quickly the work of Kastritis. This study actually included patients with paroxysmal AF, with a normal heart, and they divided the groups in the patients in three groups. The one who received only PVI isolation, one who received only ganglion plexi isolation, and the third group who actually received a combined PVI plus ganglion plexi ablation. The population was quite young, and the left atrial size was between 48 and 49 millimeters. What you can see here in the Kaplan-Meier at almost 2 years of follow-up, that the association of ganglion plexi ablation on top of PVI got better results of PVI GP ablation alone. So that's it. I mean, this was actually a trial done with the radiofrequency. Our group, has clearly demonstrated that also cryothermal energy can actually modulate ganglionate plexi. This is actually what we are doing, currently in UZ Brussels to obtain a clear understanding of what's happening before and after ablation. So we used this extracardiac vagal stimulation through a cardiopulmonary catheter, and you can see in this clear example how, the extracardiac vagal stimulation can actually induce a systole for 40 seconds, followed by induction of atrial fibrillation. After you deploy the cryothermal energy, this actually extra stimulation doesn't create any asystole nor atrial fibrillation. So we actually are speaking about ganglion plexi ablation with thermal energy. Are these results still applicable, in the era of pulsed field ablation? I mean, this is a beautiful picture from Dr. Zaher. I mean, it's going to publish a review on this topic, and you can clearly see, that this kind of ablation is preserving nerves, esophagus, and vascular structure. So, I mean, how can we apply these results now that pulsed field ablation is going more and more? I want to cite the work of Dr. Del Monte here, saying that actually he concentrated his attention on understanding if there was a clear difference between, the autonomic modulation done with PFI in comparison with cryoballoon ablation. And what we can see here with extra cardiac vagal stimulation, you actually got no difference between and after ablation with PFA, whereas after cryoablation, you clearly just eliminate all the vagal responses that we got before the ablation. So for sure, in this kind of example of patients, we can see that PFA doesn't affect autonomic nervous system. In particular, what actually was very clever from Dr. Del Monte was actually to see if this effect was actually temporary. And if indeed, in patients, in a cluster of patients, he demonstrated that, in effect, there was a modulation of the autonomic nervous system just outside the application, and this modulation was actually lost at the end of the procedure. This is on the left, the number of seconds of pause with the extracardiac stimulation. So given the cardioselectivity of PFA and the role of the cardiac ANS modulation in the treatment of paroxysmal AF, what we should expect technically is a loss of efficacy of PFA in the medium and long-term outcome compared to thermal energy. But is this correct? And I want to cite this paper, Giambattista already presented from Dr. Della Rocca and all the group. It's a beautiful paper, a propensity score match comparison, putting in comparison the three forms of the trick technology currently used for atrial fibrillation ablation. And what we actually should have expected that PFA was actually doing worse than the others. But as Giambattista already presented this morning, the recurrence was actually pretty much equal in the three groups, with probably better performance in the for AF for PFA measure. And in particular, what this study demonstrated is that PFA is also assuring a longer durability of PVI isolation. What are the possible future trials, Carlo, that we will try to implement in the future? So development of an autonomic clinic. Carlo is putting all his efforts since 2 years to develop a good relations with the neurology team. And what I propose already to Dr. De La Rocca is to develop some protocols in the lab to create a pharmacological autonomic blockade, probably by using propranolol and atropine at the same time. I use it in the past to get an idea of the intrinsic heart rate in some patients coming to the lab with syncope. We can actually we have starting using a system that can help understanding measure exactly the level of sympathetic and parasympathetic activity in our patients, and we can actually test in patients with paroxysmal or persistent atrial fibrillation after electrical or pharmacological cardioversion. So in conclusion, ANS plays a significant role in the onset of AF. This is sure. ANS modulation, in addition to pulmonary vein isolation, has demonstrated to improve the medium-term outcome of AF ablation. At the time, we cannot see any difference in terms of outcome between a PFA and thermal energy. And at the present, I'm still not convinced to buy a fully electrical car. Thank you very much for your attention.